Transplantation is the terminology we use for the use of melphalan chemotherapy. Patients that receive melphalan chemotherapy, they collect their stem cells prior to the delivery of melphalan, and then they get back a subset of the collected stem cells. And the intent of the stem cells is to speed up the recovery after chemotherapy. So really, when we talk about autologous transplantation, we are kind of bending the words here. It's really chemotherapy. The cells have no therapeutic implications. This was developed in the 1980s and fully implemented around the world in the 1990s. We still think about this as a therapeutic option to consider almost as a default for newly diagnosed patients. I think the field is gradually changing, and with access to better drugs, a lot of patients reach very good responses with combinations, and they are questioning the use of transplantation. So on one hand, we are facing the fact that the transplant is under question as a default therapy. On the other hand, we are getting better and better at taking care of patients. So patients that previously were considered to be candidates for transplant, they were primarily younger patients. So with better standard of care, better ways to monitor patients, the transplanters are open to transplant older and older patients. So on that note, older patients are also considered as transplant candidates. So in this particular case, we have a 74-year-old lady who presents with myeloma. She has renal failure. She had a history of cardiovascular disease. Most likely, if she gets combination therapy, I would think that the kidney failure can be reset and hopefully could be completely normalized. There is a possibility that she could have a little bit of a residual renal insufficiency, but probably that would not really impact her overall situation, and she probably would not have any symptoms from that. So let's say we give her 4 or 6 cycles of Cyborg-D, as we discussed before. Would she now be a candidate for transplantation? I do think if she recovers from her kidney, she probably is a candidate for transplantation if she would like to do that. She could collect her stem cells and she could go forward with a transplantation. But I also think if the patient chooses to not do a transplantation and she obtains a good response with the combination therapy, and she could go straight to maintenance therapy, that would also be a reasonable approach. So I think the bottom line is that age is no longer as strong of a determinant to consider transplantation. You could consider it for patients, I would say, at least up to 75 years of age, and maybe sometimes older if patients are in good shape. For patients that are not in good shape, any age really probably doesn't matter. If the patient is not in good shape, it's probably not a good idea. And as I pointed out, the flip side here is that if you have a very good response to combination therapy, you may not choose to do it as the default. And I think that's the direction the field is going overall. So I think the answer is both yes and no, but if the patient wants to do it, you could certainly go forward and do it.